I am Allison Agu. I'm a professor of adult and pediatric infectious diseases at Johns Hopkins in Baltimore in Maryland, where I run both a clinical program for pediatric and adolescents from prevention to treatment, as well as the young adult program from treatment, prevention, and the like. But I also do a lot of research. So research about access to care, research for biomedical strategies. I actually am part of the Pediatric AIDS Virus Elimination Collaboratory, where I run the community engagement course. What's exciting about this 2026 is that everything from the plenary, where Sharon Levin gave the whole spectrum of what's happened with cure research from different strategies, etc. So there was a lot of adult stuff, but awesome. There was a significant amount of pediatric stuff that occurred, including whole poster sessions on pediatric strategies, which is exciting because that doesn't happen all the time. Yeah. But there were a couple of things that I think really stood out. There was the baby cure, which is in KwaZulu-Natal, which is young people or actually infants that were started on early treatment. And they've reported in the past 5 of those young people, after lots of careful assessment, following, etc., meet a profile to be able to stop their antiretroviral therapy and to monitor them, so called an ATI or an antiretroviral treatment interruption. So they had reported 5 before. Today they reported 3 more, 2 boys and 1 girl. So this is the first girl, which is exciting. And one of the boys has been off ART for 52 months, which is crazy. Tatelo also, this is in Botswana, presented updates, and that's giving broadly neutralizing antibodies to pediatric patients on ART, then BNAbs, and now on BNAbs alone. And then they have been able to come off of their antiretroviral treatment, ATI, for a period of time. So really, that's 10 kids. So a lot of exciting things. Not ready for prime time, meaning it's not ready for everybody to be able to do, but giving us hints of where this could be going and what's unique about pediatric and adolescents. When we're thinking about how to support children in research, we should be thinking about how to support their entire infrastructure, family, etc., to make it possible for them to engage in that research. So asking them, meaning asking communities, what do they need to be supported, is so important, not to overuse the word, but at the beginning, before, during, and after, to make sure they can have continued participation. To get to the point where there's an ATI, or treatment interruption, they had to do all this special profiling in the lab to figure out which are those right patients who can perhaps get to where they can do an ATI. Yeah. You said pie in the sky, so I'm going to say it. It would be great to have some sort of a very quick finger prick retinal scanner to say, well, we know that you are more likely to be somebody who can come off. So some profile, but some easy way to get it to everybody, because it's not there yet. Yeah. But boy, if we could get there, it would really change the trajectory of all of it, where we could actually get to HIV cure. I would be remiss if I didn't say right now, we need to support infrastructure so people can even have access to the ART, because the first step to even get to cure is you have to get viral suppression, right? Access to treatment, access to the programs. So how do we first get that and support people is number 1. And then invest. Being creative in how we do this to make sure that we can actually take these from where they are to where it can be something that everybody can get. So we're a ways off, but investment, advocacy are all critically important.